Welcome, everyone. Oh, okay. Welcome, everyone, to the webinar. I think we're starting to have some people joining, so we'll start in a minute. I'm just going to show the slide if you need interpretation. So the presentations today will be in English, but we have interpretation available, so you can follow the instructions on screen. There should be a little globe icon at the bottom of your screen to listen in French or in Portuguese. Guys, you can see people joining, so yeah, welcome everyone. We will start in a minute, just waiting for a few more people to join. And thanks to everyone who's introducing themselves in the chat. It's nice to see everyone saying hello. Okay, I think we've got quite a few people already, and it's 2 past 11, sorry, in the UK. So I think we're gonna start because we've got quite a lot to present today. Yeah, welcome everyone, and thank you very much for joining this webinar today. We're really excited. It's our final webinar to present the results and achievement from a project we've been implementing for 2 years, so the FGS integration project. So yeah, there's a lot to cover, and we're really excited to have you all here. So before we start with the presentation, just a little bit of housekeeping. So I'm just going to show this slide, which shows you how to listen to interpretation. So the presentations today will be in French. The presentation will be in English, but we have interpretation in French and Portuguese. So if you need interpretation, please select it at the bottom of your screen on that little globe icon you can see. So you can select the correct channel for either French or Portuguese. Les présentations aujourd'hui seront en anglais, mais si vous voulez l'interprétation, nous avons interprétation en français et en portugais. Donc vous pouvez suivre les instructions qui sont à l'écran, et juste il y a une petite icône avec un globe et vous pouvez sélectionner l'interprétation en français ou en portugais aujourd'hui. So that's for interpretation. If you have any technical issues during the webinar, we will monitor the chat. And in particular, you can message my colleague Rumbi, who is the host of the webinar, and if there's any technical issue, she can help you with it. Feel free to use the chat also just to post comments and just chat with participants or with panelists. We do also have a Q&A function that's at the bottom of your screen. So if you've got any questions as we go through the webinar, please post them there, and then we will have time at the end of the webinar to answer questions. So yeah, feel free to use that function. And yeah, please make use of those chat and Q&A function. We will focus on the presentations for about an hour, but we should have about 25 minutes or half an hour at the end of the webinar to answer questions. So you'll also be able to verbally ask questions by raising your hand. Yeah, I think that's it. So Just to take everyone through the agenda of the webinar. So this is what we will go through today. Like I said, we'll spend about 1 hour or so on presentations to leave a bit of time for questions and discussion at the end. So I'll start. My name is Delphine Schlosser, and I work on the FGS integration project from Frontline Aid side as a senior advisor programs. I will just, after this introduction, I'll just take us through a very quick overview of the project, and then we'll have 4 main presentations with 4 main speakers from the project team. So first of all, we will have Liora Pile to present. So Liora is Frontline Aid's advocacy lead for HIV prevention, and she's led Frontline Aid's global advocacy work on FGS integration for the past 3 years. Currently, Liora is also the co-chair of the FGS integration group, or FIG, and she's really played a crucial role on this FGS integration project, including by leading the development of the minimum service package, which is what she will present today after the introduction. After Liora, we will have our second speaker, Millicent Uma. So Millicent is a senior research officer at LVCT Health in Kenya. And Millicent coordinated the implementation of the FGS integration and the study implemented in Kenya through this project. So Millicent will present the section on lessons learned from implementation in Kenya. Then we will have Dr. Robinson Karuga. Dr. Robinson is a consultant working with LVCT Health in Kenya, and he played a key role in the FGS integration project as a principal investigator for the study, which was one of the main components of the project. So he will present the study, introduce it, and specifically take us through his findings on feasibility and acceptability of FGS integration. And last but not least, we've got Dr. Stephen Mulupi here today as well. So Dr. Mulupi is the head of research implementation at LVCT Health, and he's a health economist, and he led the component of the study on cost specifically. So that's what he will take us through as the final presentation of today. So yeah, after those presentations, which should take about an hour in total, we will have some time for question and answers. So yeah, if you've got anything you want to ask presenters, feel free to note them in the Q&A function throughout the presentation, and we'll come back to them at the end. Okay, so just to give, before we go into really the meat of the different components of today, I'll just give a very brief overview and introduction about the FGS integration project, which we've been running for a couple of years and is coming to an end quite soon, next month. And maybe just to start with, I'll just give, for those of you who may not be so familiar with FGS, I'll just go through a brief overview on what FGS is and why we did this project. So female genital schistosomiasis, so it's a bit of a mouthful, so we will refer it to as FGS throughout the webinar. So first of all, schistosomiasis is the condition that is often better known as bilharzia, so you probably know it as bilharzia. So it's a neglected tropical disease. It's a waterborne disease, a parasitic disease that's transmitted by worms that live in fresh water. So these worms are called schistosomes, and they live in fresh water in subtropical and tropical region. And FGS specifically, it's a manifestation of chronic infection with schistosomes of a particular species, which is the species Schistosomiasis hematobium. And worms of this species, once they migrate into the blood vessel of the urogenital system specifically, where they lay eggs, and then FGS results from the immune response of the body to these eggs in the genital tract, and that leads to inflammation and lesions. FGS really affects many women. The World Health Organization estimates that up to 56 million women and girls are living with FGS in sub-Saharan Africa. But it remains still quite poorly known and also very underreported. The symptoms of FGS may include things like abnormal vaginal discharge, pelvic pain, genital burning, pain during intercourse, etc. So they're very similar to those of sexually transmitted infections. But schistosomiasis is preventable and it's treatable with a medication called praziquantel. But again, because the FGS is quite poorly understood and the symptoms are very similar to those of STIs, it's often misdiagnosed as an STI. And therefore, women are not treated with the right medication. And unfortunately, if it's left untreated, FGS can lead to very serious sexual and reproductive health complications, including ectopic pregnancy, miscarriage, infertility. And it also increases the risk of HIV, which is why it's a very important topic for Frontline AIDS and its partners. And yeah, again, because of the similarity of the symptoms with those of STIs, it also leads to other consequences for women, including exposing them to stigma and to gender-based violence. So despite this clinical presentation and the impact on sexual and reproductive health, as we've said, FGS has historically not been recognized as a sexual and reproductive health condition. Because of its treatment, condition, and reach, it's positioned generally under neglected tropical disease program. But there is, why integrate FGS with SRHR intervention, which is what this project sought to do. So like I've said, it's because of the symptoms, it's often misdiagnosed as an STI because of the similarity of the symptoms. And it's also got very serious consequences on sexual and reproductive health. The misdiagnosis also increases the risk of stigma and the possibility of gender-based violence. So it is really sexual and reproductive health and rights issue. And the misdiagnosis means that it leaves millions of women without access to proper treatment and then expose them to quite serious complications on their sexual and reproductive health. And it increases the risk of HIV, as we've said, but also HPV and therefore cervical cancer risk. Because of its clinical presentation and the fact that it can be diagnosed through a pelvic examination, for example, as for cervical cancer screening, the diagnosis and management of FGS would be appropriately positioned under reproductive health services, while the prevention efforts need to span across different sectors, including still neglected tropical diseases service points. So yeah, it's really important to integrate various sectors that impact and that FGS has an impact on, and really important to integrate it into SRHR for correct diagnosis, treatment, and managing the possible impact of FGS on sexual and reproductive health. So that's the context for the FGS integration project, which sought to integrate and test the integration of FGS in SRHR interventions. So just to give you a very brief overview of that project. So the project has been implemented since March 2023, and we're finishing it in the coming months with just a final few activities on dissemination, like this webinar. So it's been implemented by Frontline AIDS, LVCT Health, and Bridges to Development, with funding from CIFF, the Children Investment Fund Foundation. And it's been implemented in collaboration and with the support, very importantly, of the Ministry of Health in Kenya, where the project and study were implemented, and particularly with the counties of Homa Bay, Kilifi, and Kwale in Kenya, which are the 3 counties where the study was implemented. So the ultimate goal of the program was a very big goal for female genital schistosomiasis prevention, diagnosis, and treatment to be integrated into SRHR interventions, budgets, policies, and guidelines at national and global level. So it's a very big goal, and there's been lots of work to contribute to that over the past 2 years. And specifically, we had two outcomes for this project. So one on access and use of services. So the first outcome was expanded access and increased use of quality, inclusive and integrated FGS and SRH services among the target population. Quite a lot of work went into this outcome, including the development of guidance material at the start of the project. So one of the main achievements of the project was to develop a minimum service package for FGS integration into SRHR. And that's what Liora will present in the next presentation. And then making sure that the service providers in the 9 sites in Kenya are trained and can implement this integrated approach. So there was some adaptation of existing training resource, a lot of work on that. And then the training was rolled out in Kenya, and following this, the integrated approach could be implemented. And Millicent will present on the lessons from that integration in Kenya. And then our second outcome was about knowledge generation and dissemination. So outcome 2 was the evidence base regarding the feasibility, acceptability, and affordability of integrating FGS into SRHR services informs county and national level policy and funding. And that's very important because, as we've said, FGS remains quite misunderstood and under-researched and under-reported. So this evidence generation of how we can integrate FGS into SRHR, how feasible it is, how acceptable, and the cost is a very, very important component of the project and a very innovative study. So under this outcome, the main thing was to conduct a study on those 3 aspects of feasibility, acceptability, and cost of integration. So Dr. Robinson and Dr. Mulupi will present on that later in the webinar. And as well as conducting the study, we've also been conducting a lot of dissemination activities throughout the project, including through local, national, and global level events. From the start of the project, we also disseminate a lot of the other products of the project, such as the minimum service package. So that's a very brief overview of the project. I'm not gonna go into more details because we've got our 4th presentation now, which will go into a lot more detail about all these, or some of the key components of the project. So I'm just gonna now hand over to Liora, who is gonna present on the minimum service package for FGS and SRHR integration. Over to you, Liora.
Thanks, Delphine. So I'm going to quickly take you through the development of the minimum service package, and which was one of the core deliverables of the project, and basically the implementation Bible that we would use to integrate FGS and SRH in Kenya. Next slide, please. So the minimum service package for FGS and SRH integration was developed to be a programmatic guide to integrate FGS into sexual and reproductive health and rights interventions. And it was intended for use by health planners, programmers, policy makers, and I think many people on this call who work in countries and implement programs. And the MSP, which I'll call it from now, was split across 4 areas. The first area was health literacy. The second area, screening and diagnosis. The third area, treatment and care. And the 4th area, social inclusion and equity, which was a cross-cutting element. So I'll start explaining exactly what this entailed and what kind of guidance this provided under each section. So let's start with health literacy. So the health literacy section of the MSP essentially outlined, if you are doing a sexual and reproductive health program or an HIV program in a particular area of your country, how could you include FGS, health literacy and communication, and how can you integrate that into your SRHR, health literacy and demand communication. Just to note that the definition of sexual and reproductive health and rights includes health literacy, demand creation, and peer education, and it also includes HIV work. Sorry, go back to the last slide. And so this section of the MSP outlined how FGS health literacy can be included in all the kinds of activities you would do on the community level, creating demand, providing awareness, creating information, providing information to communities through dialogues, through peer education, through outreach. And this would be done as you do family planning information, health literacy and demand creation, cervical cancer, HIV, and STIs, for example. And what this would include is information on FGS signs and symptoms. So as Delphine explained, FGS has a similarity with STI symptoms. So if you were speaking to a woman in a community about STIs and about symptoms and about the need to go and get checked and the need to access services or the need to access a cervical cancer screening, you would include information about FGS signs and symptoms in there. You would also speak about the overlap that STI symptoms have with STIs and the links that FGS potentially has with HIV and cervical cancer, so that the woman is aware when talking about their sexual and reproductive health with this community outreach worker about all the risks that they may face, including a risk for FGS, which could include increase their risks for HIV and cervical cancer. The outreach worker could then include information about how FGS is screened and diagnosed, and also some, information about prevention and the safe use of water to support the community member in making decisions about how to use water and how to better protect themselves from possibly contracting FGS. The MSP then goes into detail about who would do this and where. And the health literacy element would be done by peer educators and community healthcare workers, for example, people who are on the ground in the communities raising demand. And it would be done in communities, in schools, and in facilities. So the second stream of the MSP is around screening and diagnosis. And this section outlines how an FGS risk assessment and screening can be conducted at the same time as routine SRHR interventions, such as cervical cancer screening, HIV tests, STI screenings, or family planning. And so if you're doing an STI screening or cervical cancer screenings, you can easily also provide an FGS risk assessment and STI screening. It can also detail how FGS can be diagnosed more clinically through a pelvic examination during routine SRHR services, such as STI examinations, cervical cancer screenings, and during HIV testing. Obviously, depending on the level of facility, the capacity of the healthcare worker, and the context. The second stream also speaks to how the person integrating FGS into these services would need to ensure that applicable referrals for other health concerns are in place, gender-based violence are in place, and stigma. They must, the healthcare worker must be aware of the stigma that women may be experiencing because they've been repeatedly diagnosed as having an STI, when in fact they actually have FGS. And so they may need other support, such as mental health support. And this screening and diagnosis stream would be done by clinicians and nurses in primary, secondary, and tertiary healthcare facilities. The third stream then goes into treatment and care, and it outlines how if you've integrated FGS into the other streams of health literacy and screening and diagnosis, then how praziquantel could be provided as treatment and prevention alongside SRH services or treatment, such as STI treatment, family planning, or when someone is getting ART. And it also outlines how FGS syndromic treatment and a syndromic management can be done during this SRHR service provision and integrated into that. Again, The healthcare worker needs to be aware of the possibility of gender-based violence. Women may have experienced gender-based violence because of being repeatedly diagnosed with an STI. They need to be aware that the woman may need counseling, and so referrals need to be available for these. And they should also be aware of, other SRH needs and be ready to refer on if needed. And again, this section would be done by clinicians and nurses and done in primary, secondary, and tertiary healthcare facilities. The fourth stream of the minimum service package is more of a cross-cutting stream, and this is called social inclusion and equity. And it speaks to a lot of the challenges that the FGS community is facing, but it also speaks to the mental health elements that need to be considered during FGS integration. So this section speaks to how anyone implementing FGS work needs to constantly be aware of the possible need for mental health support and how this must be provided. It could be provided when a woman is finally diagnosed with FGS because she finally has an idea of what has been wrong with her for all these years, possibly. Might need help to handle the diagnosis, but also, as I mentioned, might need support related to gender-based violence and definitely the experience of stigma. And so mental health support needs to be cross-cutting through every single piece of work that's done on FGS integration, being really sensitive to the needs of women and girls that are receiving these services. And I've spoken about the gender-based violence referrals. Another element related to social inclusion and equity was just about needing to include advocacy for praziquantel access in facilities. Praziquantel is not routinely available in healthcare facilities, and we really need to advocate for this to be the case. And also to constantly raise awareness for FGS services. And FGS, people to know about FGS, and that this would be done by all cadres of staff in all facilities and communities. So we can definitely provide the resources of the MSP. Next slide, please. The resources of the MSP to everyone on the webinar and provide you with the links on how to access this. But this minimum service package was then used as the base for the implementation of FGS integration in Kenya. I also want to say that there was a massive amount of partners that supported in the development of this minimum service package, and that really included the FIG partners and obviously then the partners of the project LVCT Health and Bridges to Development alongside Frontline AIDS. And so it really has been a project that's been fed into by a number of experts and is available for people to use. So thank you very much. Handing over.
Thanks, Leora. Great. So I think next we're going to have Millicent. If you're ready, Millicent, to present on the lessons from the integration in Kenya. And I saw a message earlier, so I hope everyone can hear okay.
Okay. Yeah, so I'm going to present the lessons learned during this integration. So just as a start, we did this integration in 3 counties in Kenya. That is Homa Bay, Kilifi, and Kwale counties. And we had 9 sites in total. Homa Bay County had 2 sites. Kwale had 4 sites, while Kilifi had 3 sites. And when I talk of sites, those are health facilities, which are supported by community units. So within this integration, I'm interested in just touching on the WHO health system building blocks, having a patient at the center, and that is the women who are being screened for HIV. So I'll touch on some of the building blocks, that is the information, service delivery, human resource, and also governance, while the rest of my colleagues will touch on technologies, medicines, financing, and feasibility, acceptability, and cost of this integration. So the lessons learned, therefore, in my presentation will be either under an activity or output of the integration. Next slide. Okay, so due to the knowledge gap, we found, because FGS is still a neglected tropical disease and actually a neglected gynecological disease. So there was need to have healthcare workers and also the community health teams sensitized about FGS in general. So using a top-down approach, we had to, first of all, sensitize the health managers who are responsible for advocacy and also responsible for even planning and also even giving the healthcare workers offs to attend such training. So we had to sensitize them first, and our sensitization for these health managers took 1 day. During that meeting, we had to bring the materials which we had already drafted for them to contextualize, including the MSP, which Leora has used as our Bible, has mentioned as our Bible. So we had to contextualize it with them. So that was very, very needed. So from then we had an okay to go ahead to train few healthcare workers, and these few healthcare workers were basically initially the champions, the cervical cancer champions. And why we needed them is that we needed not to start from scratch, to start training someone on how to hold a speculum, but we needed someone who is already equipped with the knowledge on how to hold speculum. And they've been champions on cervical cancer screening and management. So we hired them. Then after that, so this training for the healthcare workers took us 3 to 4 days, though it was quite a crushed program. So we had modules, refresher modules for the cervical cancer screening, and also modules on the female genital schistosomiasis, which was basically touching on the 4 areas of the MSP. Then, just the same as what we did with the health managers, we had a session on where we contextualized the MSP again with them, just to check on areas which needed to be realigned based on their understanding, and also the IEC materials which we had already drafted. We wanted also to have their buy-in and also their input. So that was that. Then the last day, we had to take them through practical sessions, and I'm glad that in this project, we had a consultant gynecologist, OBS-GYN, who was with us all along, and she was able to actually help the trainees understand how to diagnose FGS using also the IEC materials we were having. We also had a session of sensitizing the community health teams, and that is community health promoters, community health assistants, and community health officers. So because this team are actually a link on how patients receive information from community level to the point at which they are referred to the facility and back to the community. So there's need to have them sensitized, and also for the fact that the health facilities currently are we have community health units who report to the health facilities. So there was need to have these community health teams sensitized about the FGS. So this sensitization for the community health teams took 1 day for us. Yes, next slide. Okay, so as you can see, we had we reached quite a number of teams during the sensitization meetings. So from the health managers, we had a total of 53 health managers. So when we are talking about 53, it's cutting across the 3 counties we are working in. And also for healthcare workers, we reached a total of 75 healthcare workers as champions. And from these healthcare workers who were champions, or rather taught, they were able to reach 700 plus, and they are still continuing to reach other healthcare workers or their colleagues who are not met during the training. So they usually have CMEs, that is continuous medical education, and also during on-job trainings where they take their colleagues through FGS screening, diagnosis, and management. For the CHPs, we managed to reach a total of 345 across the 3 counties. So these CHPs have been able to sensitize the community or create awareness to the communities where they're coming from. And they've also been able to refer FGS suspected cases to the facilities during their community dialogue. So during community dialogues, they would go to the churches, they would go to the marketplaces, any gathering, they would go to schools and just to sensitize people about FGS, and they are still continuing to do this. So the lesson learned in this is that there's need to include genital schistosomiasis, that is female genital schistosomiasis, and male genital schistosomiasis in medical curriculum, because it's a gap. It's a gap we noted from the top managers coming down to the community health teams. So there's need to include it in the curriculum. It's never mentioned in the medical training. The only thing which is mentioned is bilharzia. Beyond bilharzia, there's nothing like FGS. So it was quite a gray area, and we are glad we've reached so many people within this short time, and we are hoping that they're still continuing to cascade the information. Next slide. Yeah, so under service delivery, so this project has been able to identify cases of misdiagnosis, as Leora had put it, that FGS signs and symptoms mimic those STI symptoms or UTI symptoms. So there were several cases which had been misdiagnosed as STIs or presumptive cervical cancer cases. And as such, you find healthcare workers giving antibiotics unnecessarily. And these antibiotics at the long run may even lead to antimicrobial resistance. There were also cases where a patient is told that they have presumptive cervical cancer lesions, because FGS also present with lesions at a very chronic stage. And so it becomes very difficult for healthcare providers to distinguish between an FGS lesion and cervical cancer lesion before training. But after training, they've been able to do so. So we have cases where clients were subjected to traumatizing procedures like thermal ablations, being told that they have cancer. But the condition didn't stop, the condition just wasn't. So this leads to self-stigma, isolation, and also low self-esteem, because you find if a client is having foul smell, so the stink from this smell makes this lady not even to be comfortable sitting in public places where there are women gathering, and also because of the kind of information they are getting from healthcare providers, like repeated clinic visits to the hospitals, they find like, what kind of a UTI or an STI am I having, which is not resolving? So they tend to have low self-esteem. This, what you're seeing on the screen is just an example from Nation Media Group, from one of our clients as a beneficiary who underwent a lot of trauma because of being misdiagnosed, because of being misdiagnosed as having an STI, later being misdiagnosed as having presumptive cervical cancer, and went through thermal ablation. Later on, when she decided now to come to the clinic in 2024, she got treated, and up to now she registers quite good health, and we are glad that this project has really helped several women. She's just an example, and so many are coming in even after the Nation Media Group posted this or aired this. We are having calls from several clients coming in for treatment. Next slide. Yeah, so what we learned as a team is that this needs to have adequate engagement with the stakeholders on the ground, and that includes the county teams, and that's why we started with that top-down approach. Since these people are also the same people who would also help to approve the project, so there's need to really know them, give them information in advance, because sometimes you find the project's timelines coincide with the county timeline. So if there's no appropriate engagement, then you find the activities delayed. So we ensure that we had adequate engagement with the necessary stakeholders, and we got the necessary approvals before conducting this study. And what we also learned during the approvals is that different counties have different procedures of approving a study. For instance, it would just be an email with necessary attachments. For some, they will be having a portal where the study documents or the necessary approval papers are supposed to be submitted into, so that they can review, then get back to you. For some, you would go there physically and present the proposal. So that is why it is really necessary to have adequate stakeholder engagement. Through this engagement, we've realized that the teams, the 3 counties are quite receptive, and it has influenced even procurement of praziquantel, which was initially available during MGAs only. When we were starting, we didn't have enough praziquantel. But as we are ending, counties are having praziquantel, and they are even tapping on other resources like available partners on the ground to help them continue with the FGS integration. So as we mentioned, as I also gave the example of that client we've just seen in the previous slide, women also experience a lot of comorbidities during FGS screening, and some of them would warrant maybe further investigations which are not necessarily FGS related. For instance, there were cases where we were getting a client who does not have a cervix, yeah. For the doctors in this call, or gynecologists in this call, you'd understand that some women are born without a cervix. So such warranted further medical attention, which was not within the FGS integration. So those women were supposed to part with some money to cater for their other comorbidities, which were identified during the screening. So to some, it was a burden to them. To some, it was a relief because they didn't know. It was a relief of something they never thought of having, or it was a relief that maybe their struggle of maybe getting children was now being identified. There was also a need to have some success stories which would make the communities build trust about this integration and also counter misinformation. For instance, in some cultures or in some communities where we were working, urinating blood was normal to these people, and so it wasn't a problem. So one was supposed to urinate blood in his or her lifetime before they're saying they're named as mature. So if we have such kind of success stories like the one we've just shared, and amongst others which we've shared in other platforms, then it demystifies a lot of myths we've been having about some signs and symptoms of FGS, and also ensure adequate community sensitization amongst the communities we are working in. So during our integration, the posters we had, we managed to translate them into 2 languages, that is Swahili and Dholuo. Of course, the original template was in English, so we were having 3 languages. But as we were disseminating, we had a recommendation that in future, we need to really consider all the languages, the native languages on the ground. As you know, Kenya, we have so many languages. It's not 1, it's not 2, it's about 47 languages, 43 languages in Kenya. So for the coast, those are the tribal languages which we were recommended to have besides the Swahili, because the assumption was that in Swahili, in coastal Kenya, most people would speak Swahili. But if one would have it translated in their mother tongue, the information would reach home better than if it was translated in just Swahili. Next slide. Yeah, so just more on the lessons. As we were just about to finish this project that was towards October, November, and December last year, we realized that we had concentrated or spent more time in trainings and sensitizations and also facility screenings. So the MOH in the 3 counties had an initiative on how to beef up the screening numbers. And so with the same token that most women who suffer this FGS suffer low self-esteem and also stigma, most of them would still just be at home because they've lived with this FGS for so many years. You find some have lived with this FGS for even since 1996, since 1997. For the shorter ones, maybe 1 month. Those ones I would say acute cases. Yeah, but people live with them. So we realize that if you expect women to come to the facility, such women who had suffered low self-esteem will not come. But if you take the services to their doorsteps, they would come. So that was the initiative from the MOH, where we had to do outreaches, and we got so many women who are suffering, including men who came to seek the services, and they were asking, why is it just a female agenda? Yet we share the same environmental risk. Yeah. So the healthcare workers were quite innovative. And as we may know that in a rural setup like in Kenya, where resources may not be enough, the outreach would only suffice if the healthcare workers would be innovative enough, like being given a room where maybe the doors or the windows are wide open, and you want to do a procedure which needs quite a lot of privacy. So we had to be very innovative during the field with the MOH staff, just to ensure that the numbers were screened. And we are going to see how we fared on during the outreaches. Yes, so next slide.
Listen, just say we're more than 10 minutes over, so if you can wrap up the final few slides quickly, so we have time for the next presenters as well. Thanks.
Okay. Yeah, so this is just a summary on how the integration went from the numbers we screened, coming to the pelvic exam and the positive cases, so positive for FGS. And remember, we were doing an integrated approach. So this was just for FGS only. As you can see, outreach, as I've said, we had a lot of numbers. We had 71% positivity coming up to, and the next was maternity and child health department, where we had 28%. And the last one was the outpatient department. So we acknowledge that the healthcare workers really did a good job, because doing a pelvic exam, for instance, at the CCC, the Comprehensive Care Clinic, where we had 100% screened and 100% pelvic exam, meaning all women who were screened at the CCC volunteered for pelvic exam, irrespective of the fact that they had lower numbers who are positive. Next slide. Okay, so this is positivity by county. As I had said earlier on during my my intro, we had different. We had number of facilities who are participating, and for Homa Bay we had 2, Kilifi 3, and Kwale 4. So for Homa Bay, the positivity rate was 28.5, and for Kilifi was 15, and also Kwale we had 34%. So in terms of the leading counties, Kwale had 34, followed by Homa Bay, and then lastly, Kilifi. Though we have also mentioned in terms of the number of facilities which were participating. So it can make sense to someone analyzing it keenly. Next slide. Okay, so so this is just, I hope it's the last on the lessons we learned. So this was just a pilot study. Hence, we didn't exhaustively concentrated on all the schisto-endemic areas in the 3 counties where we are working. So like in Homa Bay, there are some counties which we didn't work on due to some logistic issues, and also same to other counties like Kwale. But the fact that this FGS information had spread, so we were having clients being referred from these other areas which are schisto-endemic regions, from the counties where we are working to the facilities. And so it means that the burden of this disease is wider than what we are presenting today. Again, during our training, we didn't mention the fact that FGS can actually present as a bladder mass. And this was one of the findings we were getting during screening. So you find men or women coming with history of swollen bladder. And when biopsy is done, then the results turn out to be schisto eggs being revealed or being seen. And same applies to urine sample for microscopy. So there's also need to have that in mind, that all the swollen bladder may not just be a sign of cancer, it could be schisto. Next slide. Okay, so this was quite a lesson or kind of a finding that FGS, being something which is not known, it doesn't have a register. So the only register we could find to record all the indicators of FGS was cervical cancer screening register. The healthcare workers were quite innovative. So under the remarks section, just at the edge of the register, they would draw a line and indicate whether the FGS screening has been done and the outcome. So some would indicate 1 for negative, 2 for positive, and ND for not done. Yeah, so, but we realized that the space is not enough, because we would also wanted to see what about the follow-up. Yeah, so they would squeeze and write in their abbreviations, but there's need to have a register, and it's one of the advocacy messaging we are having to the national team to ensure that the FGS or schistosomiasis hematobium has a register where healthcare workers can record the findings or the indicators. Next. Okay, I'm done. Thank you.
Thank you so much. So we'll hand over to Dr. Robinson Karuga now to expand on the study and specifically results on acceptability and feasibility. Just to say, we are running over time, but if there's any question that we don't have time to answer, we will send a recap email after the webinar. So feel free to carry on asking questions, and we'll see how to take them on at the end. But yeah, Robinson, if you could try to keep more or less to your 10 minutes, just so we have time also for the results and costing, that would be great. Thank you.
All right, greetings everyone, and thank you very much, Delphine. I'm really delighted to be here and share our research findings. So we had 3 research questions. The first question was about acceptability of integrating FGS and routine SRH services. The second question was about feasibility. And the third question, it was about the cost of integrating FGS and SRH. So that will be covered by my colleague, Dr. Mulupin. Next slide. All right, so yeah, so we used an implementation research approach, and here it was a mixed method approach. We combined both qualitative and quantitative research methods concurrently, and we conducted this study different styles of the health system, right through from the referral hospital. So we were collecting the health workers, community health workers, the clients, and the community gatekeepers. Next slide. Yeah, so we were very, we screened all the participants who participated in this study. So they had to be adults above the age of 18,
Robinson, so sorry to interrupt. It's breaking out a little bit, so maybe you want to switch off your camera for a bit.
Okay, all right, sure. Let me switch that over. I hope it's better now. All right,
Yeah,
yeah.
that's
So yeah, so for the thank you. So for the participants, the clients, they had to have resided in the study site, and for it was important for them to have delivered the services for at least 12 months, and all our participants gave the written informed consent. Yeah, yes. Has it moved to the next slide? All right.
It's on the method
Yeah.
data collection slide now, Robinson.
Okay, yeah. So for the data collection methods, we use a combination of interviews, focus group discussions. We had a survey on the acceptability of this integration with health workers and clients, and then we reviewed the health records, conducted data audits, and we also conducted data reviews. Next slide. Okay, yeah, so in the interest of time, I will not take so much time here, but this table indicates the number of participants who we worked with to collect the data. So it shows you we had a rich mix of research participants across the entire study. Next slide. All right, so acceptability of health services is a construct because it's not directly observable, but we can measure it through indicators or the responses. So to assess acceptability of integrating FGS and routine services, which has 7 constructs, from ethicality, affective attitude, the burden, opportunity cost, effectiveness, self-efficacy, and coherence. So those are the 7 constructs, and we designed our research tool to reflect each of these constructs. So since we're running behind, allow me not to go through each of the constructs, but we'll jump directly to the acceptability. Now, amongst the clients, we saw that acceptability was very high when we analyzed all the 7 constructs. Acceptability was at 98.8%. So literally, almost all of them agreed to participate that this integration is acceptable. And for the health workers, as much as there were few, 97% of them across the different study sites found this integration acceptable. Next slide. So moving forward, we will share with you the qualitative findings on acceptability and feasibility. But when we share the slides, you'll see the representation of the other constructs. So health workers did not know about FGS at all, and they said all throughout their practice, they had diagnosed FGS and STIs, and they were very relieved that they could finally offer quality services by correctly and accurately diagnosing FGS. After the training, the health workers said they felt very confident to conduct correct diagnosis of FGS. And the health workers said this was a very important training that needs to be embedded in pre-service curricula. And if I may add, they also said they needed additional CMEs or continuous medical education. And in terms of the quality and efficiency, health workers mentioned that this integration was very efficient for clients because it eliminated several trips to the health facilities for different types of diagnoses. They could do this all together. Next slide. Yeah, so when you look at acceptability amongst the clients, the clients really generally felt safe when they were undergoing the pelvic examination, and they were relieved that finally they received correct diagnosis after several instances of misdiagnosis with STIs and the stigma. And when we spoke to the community health workers and health workers, they said they were really motivated to continue integrating because they were happy with the positive outcomes, and the fact that they were helping their clients correctly diagnose what was ailing them. Next slide. Yeah, so there were a bit of challenges when it came to integrating these services. So the first one was gender related. Some of the women preferred having the pelvic examination done by female health workers. So sometimes they had to queue for longer to be seen by a female health provider. Spousal consent was important in some in some areas. So we found some women didn't have the age urgency to have the pelvic examination done before their male spouse agreed to do this. Then some clients were also anxious about pelvic examination due to probably the communication from the health providers. You can see from the quote there, health workers might require some training or bedside manners when they're providing these services. So you will be able to interact with this quote when we share the slides. Next slide. Yeah. So as mentioned by Millicent earlier on, was a challenge. This was a key concern amongst the health workers. So yeah, so that had been emphasized by Millicent, but yeah, we can move on to the next slide. Okay, yeah, so in terms of feasibility, so the health workers perceived integration as a means of enhancing the quality of care with very marginal additional investment. And they also found that integration was practical because they used the same beds, the same lamps, the same capital. They didn't need to quantel for dealing with the adult warmth. The health workers requested for additional mentorship and supervision. And when it came to workload, very few of the health workers reported about there being more workload. But the only concerns that came that could bring about workload was understaffing. And then some of them felt that they could not release their clients without having done a pelvic examination and looking for FGS. So that was a really go that extra mile. Next slide. Yeah, so I believe this is my final slide, and the key takeaways would be, we saw that the community outreaches, maternal and child health department, and the outpatient departments had the highest yields for identifying female genital schistosomiasis, and there would be the second key takeaway was to be important, and this is an advocacy message, to incorporate treatment and management of FGS into existing protocols and clinical guidelines. There was a recommendation to include FGS in pre-service medical training curricula and also in-service training. Incorporation of genital schistosomiasis into health management information systems is important because this will help with practice. Then it will be important to ensure that the sustainable supply of diagnosis and treatment commodities. And finally, we did this study implementation research in a small area, but I think it's really important to scale this up within the same counties and to other counties where FGS has a hidden burden. Thank you very much, and I'll hand back to you, Delphine. Thank you.
Thank you so much, Robinson. And yeah, next we're gonna hand over to Dr. Stephen Mulupi for the findings on costings from the study. So over to you, Mulupi.
Hi, everyone, and thanks to Robinson, Millicent, and Delphine for the earlier presentation. So I'm going to focus on the main question that policymakers always ask when you present them research findings is what is it going to cost? That's what we set out to do, to fill that important evidence gap. Next slide, please. So when you're costing, you want to really understand the perspective, and this indicates who is paying for the health services. And in this case, we used the health system perspective, predominantly taking the perspective of the county government, of the Ministry of Health, paying for services and therefore being able to kind of budget. But you also collected some data on the user perspective because there's a cost to accessing services. So we started by identifying all resources that go into these diagnosis and treatment. And then we attached monetary value in terms of Kenyan shillings. And then we did some bit of analysis to project different scenarios that are important for decision makers. Next slide. So I'll talk about two main types of costs. So we have capital costs and recurrent costs. Capital costs involve, for example, training, equipment, and other assets that have a useful life of at least 2 years, at least 1 year. On the other side, you can look at recurrent costs as the operational costs that you require to maintain a service. So if you take an example of a car, if you purchase a car, what you spend is the capital cost. But the other cost of running it, licensing, and fueling would be the recurrent costs. I used a top-down costing method, both top-down and bottom-up, meaning for top-down, we are just looking at activities as aggregate costs. So, for example, during training, we could hire venues like hotels. There's a package for every participant. That's like an activity cost. But for granular costing is going all the way down to how much a tablet, how much a glove that is used for providing services actually cost. Then you'll be able to estimate cost based on the number of people who are consuming. We excluded sunk costs like infrastructure. The facilities were already there, so we did not need to attribute any cost of building them or maintaining them. They'll be maintained anyway, even if we don't have FGS services provided. Next slide. So on the side of patients' costs, we want to focus on direct and healthcare costs and monthly household expenditures. So whenever people access facilities, they must spend some money on travel, they might have to eat or something like that. This is money coming out of pocket. We did not collect direct healthcare costs, which could be costs where people spend for any activity or any service in the facility, because this study provided drugs, they provided the speculums and all other medical supplies that were supposed to important for the implementation. Because in our settings, we do have facility stockouts, we did not want interruptions. So we are able to get this data from the procurement and finance records. But for direct non-medical costs, these are only collected from patients, and also collected their monthly household expenditures to be able to just gauge aspects such as poverty and ability to pay and all that. Next slide. So very quickly, a recap: healthcare workers were trained, women were screened when they came to the facilities, positive cases were noted, and we abstracted medical records to get the number of people who had received pelvic examinations and those who had turned positive. And amongst these women, we engaged a smaller sample in interviews to just get to know about their household expenditures and also what they've spent coming to the facility. Next slide. So out of facility records, in the 9 facilities, 6,234 women accessed pelvic examinations. and we got this data from the review of the records that Millicent has shared. We also looked at financial and procurement records to document everything we ever purchased for this intervention. And we interviewed 927 women to understand their user costs. And we got community health worker reports from their supervisors about the reach of mental health literacy. And you see there, we achieved around 55,000 women, people in the community who had received this literacy. We consulted with the experts to understand how service should be provided, and that informed the resources and other plannings. Next slide. So very quickly, out of procurement records, we applied market rates. So this study presents real expenditures and the most accurate estimates about our costings. We did some bit of analysis to cater for inflation, and currencies were converted to US dollars at market rates, but there's also what we call the international or constant dollar to kind of estimate the purchasing power of money across the world. We annualized costs and did some sensitivity analysis to be able to project different scenarios for decision makers. Next slide. So I represent the total cost of implementation. There's the total cost of implementation covering all the resources that went in. That is important. But then there's a more important step of presenting the cost of integration. Now that is very specific to what is unique in FGS. Facilities always have gloves. They do have speculums and all that. But what is unique for FGS? Then there's a presentation of unit costs of implementation and integration. And just pointing out that we did discounting. It's estimated that it's assumed that $1 today has more value than $1 next year. So if you are given money today, it would have more value, and therefore you have to discount for money that you'll receive next year. It's an adjustment to value money, and it's called net present value. Then you also identified cost drivers. These are the significant aspects of cost that are important for decision making. Next slide. So over the next 3 minutes or so, I'm going to present the key highlights. First of all, out of the 927 exit interviews, the mean age of these women was 33 years. Majority had were in monogamous marriage relations. Majority were less than 30 years old, and about 35%, slightly above 35%, had secondary education and above. And this population, in terms of occupation, majority were either casually employed or unemployed. When you put those two together, it's about 78%. That tells us that they are highly dependent on other people, for example, spouses or partners, for decision-making to go to the facility. Average monthly household expenditure was 6,189. I leave it to the audience to gauge who here can survive on $48 in a month. You pay rent, food, and all other things on $48. Next slide. So on non-medical expenditures, the travel was the highest, about $1.2. But overall, it's non-medical expenditures are averaging about $2.2 or 289 Kenyan shillings. Next slide. The total cost of implementation, that's putting community costs and health facility costs, was about $85,800. And majority or the bulk of these costs were spent at the facility level. That's 86%. Next slide. For community costs of this 55,000 women who are accessed, it translates to about 0.3 USD, and still capital costs accounted for a bigger percentage of the intervention at 62%. Next slide. So facility-based costs, again, capital cost was accounting for a bigger percentage of the costs. And when you look at the cost drivers, you see training amongst capital cost, training consuming 93%, information materials about 6%, and equipment coming to about 1%. Overall, at the facility level, we're having about $75,000 spent. Next slide. So this is an example of the recurring costs that we spent. We have all the way from gloves to sanitary pads, but we highlight praziquantel as the main cost driver at 43% of the recurring costs. So if we assume that all those other costs that we have listed here, the gloves, acetic acid, jig, applicator sticks, and speculums, cotton, these are things that you would ordinarily find in the facility. So praziquantel cost stands out as the main recurring cost that we are taking into integration. Next slide. So we did annualization, and this is to mean that for any capital cost you spend, you want to spread over the period that you can use this resource. We've used 3 years for midterm expenditure framework, or the short term of any intervention within government systems. Out of the annualized costs, it translates to, so we just divide using direct line depreciation, we divide over the number of years, and it comes to about 2.6 million Kenya shillings in terms of the annualized costs. So moving forward, I'm going to present what it means in terms of projecting the value of training of trained nurses. They're going to care for people over more than 1 year. That is an asset. You've already created awareness. So what remains is for you to put recurring costs to sustain the services. So the next slides are going to show how these projections look like. And we're going to assume that pelvic examinations will increase by 30% every year, because the nurses already have the healthcare workers have the information, they can diagnose. Community workers are spreading the information. And because positivity was 13% at a facility level, we're going to use that to estimate the number of people who turn positive for every subsequent year. And that PZQ or praziquantel is the only recurring cost. Next slide. So over 3 years, we see that the unit costs, if you look at the unit costs of per dollar, assuming 129 Kenya shillings, for the first year was 3.4. That is the unit cost of integration. Year 2, because we assume that healthcare workers are seeing many more patients, but using the same skills. So the unit costs are going down to about $2.5, and year 3, they drop further to $2.1. Next slide. So I have opportunities for supporting to providing data for decision making based on this costing. And it also provides a foundation for more health economic analysis. For example, cost effectiveness studies can build on this. We expect that over time, they might have lower costs for drugs depending on strategic purchasing initiatives within the country. And we're also aware that the CDC is developing a pooled purchasing facility, which can mean better negotiation power for medicines. And there's a significant local political support from county decision makers. So we expect that the study or the intervention will be sustainable. Final slide. So overall, this study aimed to disrupt the vicious cycle of neglect. Where's the neglect? Because you do not have data at facility level, you cannot argue for resources upwards. So Kenya is now doing going to read the national budget, and we'll have many different sectors competing for resources. Within the Ministry of Health, different programs are competing for resources still for that limited basket. So if you don't have data, there's no justification for you to argue for resources. So what this study does is that it disrupts this cycle by bringing data on the table, saying this is the data generating out of diagnosing, and that is now going to feed upwards to the decision makers to provide evidence basis for resources. And we're hoping that now with these resources channeling back to the service provision level, we'll have more data generated and more sustainability, because we have evidence to support this. I want to thank you all, and I pause and welcome your feedback. Thank you. Thank you.
Thank you so much, Dr. Mulupi. Yeah, that was a great presentation, and you can probably see now in the chat a lot of questions and comments, and Yeah, so we will take some, we've got a bit less time than we hoped, but we will take some question, and we will also, like I said, send recap email after the webinar, just so that you've got various resources, the recording to the webinar, and see if we can connect people and share email addresses as well. So yeah, thanks very much to all the presenters. That was really informative, and I think you can see the comments in the chat. We've got a few questions in the Q&A section. So I'm going to take some of those. And if anyone also wants to ask a question verbally, you can raise your hand, and we'll enable your microphone so you can ask also to the presenters. So yeah, a few questions have been answered already, so I won't go back to them, but I think everyone has access and can look at them. So Florence Wakesho was asking, do we have a field community screening tool? This might help to get more patients at community level, as some women may not go to the health facility for pelvic screening due to fear. Millicent, I don't know if you would like to answer that question.
Yeah, so thanks for the question. So besides the job aid, which we created for the community health promoters, which was quite simplified and could be understood by the community, the community health promoters were not supposed to do the FGS screening. They were supposed to refer to, their work majorly was supposed to refer any suspected case. So they would sensitize or create awareness during the job aid. And for any woman who would feel like they're having the signs and symptoms which were being mentioned, they would refer them to the facility. Otherwise, screening, the physical screening was meant for the healthcare provider. So we didn't create any community screening tool besides the job aid, which was quite elaborate with all the signs and symptoms and what the community health promoters were supposed to do. Thank you.
Thank you, Millicent. Rumi, can I just check that there's no, I can't see any hands up, but just to check that's correct. If so, I'll just go through with the question in the Q&A.
There's actually one hand up.
Oh, sorry. So
yes.
yeah, I can't see it, but if you can unmute them and over to that person.
Okay, Antonio Fernandez, please go ahead. Yes, please go ahead.
Hello, everyone. Can you hear me?
Yeah.
Podem me ouvir? I can speak both Portuguese and English. I want to know which method, which methodology they apply for laboratory diagnostic of genital schistosomas.
Thank you, Antonio. And just to say, if anyone wants to ask question in either French or Portuguese, you can. We'll just need people to switch to the English interpretation channel to hear the question. But thank you. Robinson, I don't know if, or Millicent, I can see you on screen. Do you want to answer that question?
Oh, okay. I was just putting my camera on. Okay, so to respond to Anthony, urine specimen is not used to diagnose FGS because FGS is supposed to be diagnosed physically using the naked eyes. So there are lesions, there could be lesions, there could be rubbery papules. So for urine, one would only take to the lab if they want to check if there are eggs of schistosoma hematobium, but it's not not for diagnosing FGS. I hope I've responded to Anthony.
Thank you, Millicent. Rumi, is there any other hand up, or should I carry on with the Q&A?
No other hands. You can carry on with the ones in the Q&A. Thanks,
Okay,
Delphine.
thank you. So there was a question for Dr. Mulupi, I think, from Namita Ulegadi. So could you explain what exactly is bottom-up approach in costing, particularly with FGS integration?
Thank you. So when you're costing within health economics, you want to get data that is most important for decision makers. So there has to be decisions about what is the most useful data, so that you don't go and collect very intense data and it might not have a lot of decision-making value. So those two main approaches are recommended. So for bottom-up micro costing, you are taking every ingredient that's going to the service, a particular service. So for example, if in our case, women are undergoing pelvic examination, and we purchased gloves in bulk, say, the price of a carton is this, and then there are smaller boxes inside, say with 100 pieces each. So you'd divide the cost of that carton and get the cost of the box that's inside, and you'll divide further and have an estimate of what one pair of gloves costs. Then when you discuss with the experts, they'll tell you, for example, for every encounter, maybe you need 2 or 3 pairs of gloves. So for every woman, we assume that they are consuming 3 pairs of gloves. That's now micro costing. For PZQ, you'd cost it up to the cost of 1 tablet, and then say, what is the dosage? Like 5 pieces. Then you'd say, okay, per woman, this is how much they would consume. Now, on the other side, about top down, there are certain resources that cannot be costed to the minute details. So for example, if you are hiring a hotel venue, they'll just be given a package and say, for example, in the Kenyan situation, about 3,000, 4,000 per person per day. You're not going to cost how much people are going to consume, many bottles of water they're going to consume and all that. We just know that if someone is coming to consume a certain service or access a certain service, then there's this package that they'll spend. That is the level that is meaningful for a decision maker to decide, for example, if you're conducting a training, how many people are we engaging and how much should you pay for this service? So that is in essence the main difference. Thank you.
Thank you, Mulupi. And there was another question which is also for you, related to affordability. So the same person, Namita, is asking, what about the affordability of diagnosis and treatment for the client? Is it out of pocket or part of SHS? So you've touched on it in your presentation, but if you explain.
Yeah, so affordability is a very subjective concept when you're looking at costing and access to services. And it's also because of how the society is structured. What is affordable to you might not be affordable to the person next to you. And we presented the household data so that you can have a sense of what it means. Someone is having something like $50 US, $48 for a whole month to plan how they're going to eat, to pay rent and other emergencies in the household. Then it gives you a sense of what it means, for example, to pay $2 on travel for one condition only. So the reason we collected this data is many programs for example, we've had TB programs coming up and telling people, go to the health facility, services are free. But are they really free? Accessing those services means that you have to pay out of pocket to travel. And sometimes you have some additional requirements, maybe certain types of food to eat, to take certain medication. All those are costs of accessing care. So affordability is a question that we are leaving open and exploring during our advocacy. The multiple policy actors that we've engaged so far, we've been posing that question. Do you think this is affordable? But from one of the feedback that we had with the county decision makers, one issue came out that was appealing, in the sense that the argument is, if we diagnose FGS correctly, then you are unlocking some of the system resources that are going to waste, for example, on antibiotics and all that, and there could be opportunities to channel these monies back to FGS services. But to note that we've worked with very poor communities, so there's need for other models also to complement. So Millicent has talked, for example, about outreaches. Outreaches can be a good model of kind of minimizing travel burdens to people and making services more acceptable. And we are taking from this study some of these lessons to be able to kind of inform us on the bit about the services here already, but can it be accessible to people? Is it affordable? And maybe lastly, I'll just say that with Kenya restructuring its health financing system, particularly on social health insurance fund, there could be opportunities there of people accessing these services in a much more easier way if they've been covered by these programs. Thank you.
Thank you so much, Dr. Mulupi. We're at time, so we're going to have to close this webinar. But just to say to everyone that we will send an email after the webinar with the recording, some of the materials. There will be an email address in case there's any more question or you want to connect with some of the presenters. And I know we've got a couple more questions in the chat or in the Q&A, so we'll try to gather those and also answer in the follow-up email if that's okay. But yes, thank you everyone. Thanks very much for attending. And also I want to thank particularly all the presenters today, Dr. Mulupi, Liora Pillay, Millicent Uma, and Dr. Robinson Kauga for their excellent presentations. There are publications that are upcoming this year that Robinson, Mulupi, and the team are working on. So yeah, watch this space that will be coming out hopefully in a few months, the journal articles. But we will send a recap email with a bit more information and signposting you to the relevant resources after the webinar. So yeah, thanks again to everyone who attended, to the presenters, and also to all the project partners. So Frontline AIDS, LVCT Health, and Bridges to Development, as well as our founder, CIFF, and our Ministry of Health partners in Kenya as well. So the Ministry of Health of Kenya and the counties of Homa Bay, Kilifi, and Kwale. Thank you, everyone. And yeah, have a good rest of the day. Bye.
Bye. Thank you, everyone. Bye.